Hello, everyone. All right, we're going to get started with our next session. My name's Amanda Bergen. For those of you I haven't met, I work closely with Kate at the foundation, and I also have a daughter with Phelan-McDermid syndrome. Her name is Hudson, and she's about to turn 9. I am so honored to get the chance to introduce Dr. Sid Srivastava and Dr. Michael Schön with us today for our session on clinical care guidelines. Dr. Srivastava is a child neurologist, neurodevelopmental disorder specialist, and professor of neurology at Harvard Medical School and Boston Children's Hospital. I know a lot of you have probably met him with his essential role in the Phelan-McDermid syndrome natural history study, his work in the clinical care guidelines, and the neuropsychiatric consult group. Dr. Schön, research work group leader at Ulm University, is a prominent figure in the Phelan-McDermid syndrome community, serving as a board member of the German Family Organization, chairman of the new European Phelan-McDermid Syndrome Research Consortium, and he's also an active member of our scientific advisory committee for the foundation. He also sees people with Phelan-McDermid syndrome in the clinic. Together, they're going to summarize the 2 sets of international clinical guidelines released in 2023 for monitoring, managing, and treating symptoms of Phelan-McDermid syndrome that cover different areas such as genetics, communication, sleep and GI disorders, and more. They'll explain how these guidelines are developed, how families can use them, and where you can find this information. So please join me in welcoming Dr. Srivastava.
Excellent. Thank you so much for that introduction. It is my true honor, true privilege to be able to speak today about some of our efforts to develop a U.S. consensus-based guidelines for Phelan-McDermid syndrome. I'm going to start this talk by talking about my background because I think it really helps frame why I'm really passionate about this community and why this work is so meaningful to me. I grew up in Baton Rouge, Louisiana, and I went to undergraduate at Columbia University in New York. And then I did my med school at Johns Hopkins and did my residency in neurodevelopmental disabilities at Kennedy Krieger. And it was there that I saw my first patient with Phelan-McDermid syndrome, a boy with autism and severe self-injurious behaviors. And I remember thinking 2 things. One, just how interesting this condition was, but at the same time, all the set of challenges this family experienced and faced, and it really made me want to do something to help that family in this community. I went to Boston in 2016 and I did a neurogenetics fellowship and have stayed on as faculty since then. And at Boston Children's Hospital, I run our developmental neurogenetics program where I see patients with Phelan-McDermid syndrome and other genetic neurodevelopmental disorders. And it's been such a pleasure to get to learn from families and to really understand the challenges that they face. I've been really privileged to be a part of what we call the Developmental Synaptopathies Consortium, which you've heard about before. This is a consortium that is studying the natural history of Phelan-McDermid syndrome as well as 2 other genetic conditions. And that was through the efforts of Mustafa Sahin, who invited me to join this consortium when I joined Boston in 2016, 2017. This consortium, of course, has multiple sites and has been collecting really quantitative, comprehensive natural history data, as well as biomarker data. And one of the goals of this consortium was to develop a comprehensive clinical care model of Phelan-McDermid syndrome based on the learnings and teachings that we have discovered from this research collection. So as you know, in 2014, Dr. Alex Kalabzon published the first clinical care guidelines for Phelan-McDermid syndrome, which provided a pretty comprehensive overview of the condition. But there certainly has been a need to update these guidelines, and there are 2 basic reasons for it. The first is that we have published and learned so much from a research standpoint over the intervening 10 years. We have published studies from randomized controlled trials. We've published studies about large genotype-phenotype correlations. We've published studies about neurobehavioral phenotype and features of this condition. And this has really helped shape our knowledge and understanding of the condition. And at the same time, our clinical experience has grown significantly. We've seen many, many more cases as clinicians, and that really helps frame our understanding of what is important and what needs to be addressed for families. These are just an example. These are just a few of the examples of the many papers that have come from this consortium and work from others. I wanted to highlight work from this PMS neuropsychiatric consultation group, which is basically a way of providing consultations to providers who care for individuals with Phelan-McDermid syndrome and having ability to interface with experts in this condition who can help manage some of the very challenging psychiatric and behavioral manifestations of this condition. I'm, again, very lucky to be part of this wonderful group of peers who consult with clinicians who take care of patients with challenging cases. And I think that has also really been helpful from a clinical perspective in terms of as part of this consultation group has allowed us to create workflows and pathways, algorithms for approaches to different conditions or different sets of challenges within Phelan-McDermid syndrome, including hyperactivity, irritability, aggression, anxiety, mood issues, sleep issues, and catatonia. So going back to our goal for updating these guidelines, it's really kind of mainly to update our recommendations for clinical management that reflects our latest in terms of our knowledge of Phelan-McDermid syndrome. And importantly, that provides some updated guidance to clinicians, to researchers, to family members, to the general community. I'll mention just briefly, when we started these guidelines, again, just a small point is that we focused on those on Phelan-McDermid syndrome defined as on those with SHANK3 involvement. And I recognize and fully acknowledge that there is a subset of individuals who do have chromosomal deletions that don't involve SHANK3. But for the purpose of these guidelines, we really focused on SHANK3 involvement, given that all of the research that we've done a lot of the research that we've done has really focused on those who have involvement of this gene. I and Dr. Kolevzan co-chaired this working group that included experts from multiple different fields, including neurology, including psychiatry, including genetics, cardiology, GI, kidney specialists, physiatry, endocrinology, and primary care, dentistry, and others. I think this point is really important, is that we involved family representatives as part of each of these work groups as best as we could, and we involved the PMS Foundation from a very early standpoint. I think it's really important to have the family experience help shape our clinical guidelines, because ultimately these guidelines are what the families will take back and use. In terms of the structure of how we try to develop these guidelines, for each of these major domains, such as psychiatry, neurology, GI, and so forth, we try to address two areas. One is we try to summarize an overview of the common set of challenges pertinent to that domain. And the second is we try to come up with salient recommendations pertaining to what things should we assess for within that domain, what are things that we should be monitoring for over time, and are there any treatment-specific recommendations or PMS-specific treatment recommendations that we could suggest? Here is a timeline of our progress. We started this idea 4 or 5 years ago in 2019 and started assembling our first subgroups in 2020. So it's taken about 3 or 4 years to get to this time point. We met regularly over the next 2 years between 2020 to 2022. We came up with our first draft of these guidelines in January of 2022 and published them in August 2023, and in parallel with Dr. Schön's group, who you'll hear about next. Here is the final draft of the published guidelines. There's a link below and there's a QR code, but the PMS Foundation will also give some information about how to download these guidelines as well. It's a freely accessible PDF that anybody in the community, researchers, clinicians, family members can access. So next, what I'm going to do is I'm going to kind of walk through each of the major areas. And again, this is more of a whirlwind tour just because of our limited time and because each of these areas is filled with a lot of really important information. So this is just a broad strokes overview, but happy to take questions and answer questions afterwards. So first category in genetics, and I think the main takeaway here is that there's a lot of nuance, and there can be a lot of nuance and complexity to the genetics of Phelan-McDermid syndrome, but one key takeaway is that in those who have 22q13 deletions detected on, say, a chromosomal microarray, I think it is important to look for the presence of a ring chromosome using a technology called karyotype or FISH. And a ring chromosome is basically when the two ends of the chromosome truncate and form a ring structure. And this is important to know because this has a little bit differences in terms of what we surveil for, because that ring chromosome 22 can predispose to a condition, manifestations of a condition called neurofibromatosis type 2, which has risk for certain types of tumors and lesions. So ring chromosome 22, or detecting the presence of this, is an important consideration in those who have a 22q13 deletion detected on, say, a chromosomal microarray. Next, let me talk about neurology, and specifically MRI first. A lot of families ask, well, when should we ever have an MRI in our child or individual who has Phelan-McDermid syndrome? And the answer is we don't routinely suggest MRI for anyone with Phelan-McDermid syndrome. However, we do suggest MRI if there are certain indications, clinical indications for an MRI. These indications include if there are neurological findings on their exam, particularly focal findings, which means that one side of the body is affected more than the other. If there are seizures, particularly focal seizures, meaning seizures that emanate or originate from one part of the brain. If there's concerns for increased pressure inside the brain, which can manifest as progressive sleepiness, progressive vomiting, and so forth. If there's developmental regression, meaning loss of skills of pertaining to motor, cognitive, speech, or other domains. If there's macrocephaly, which is an enlarged head size, or microcephaly, which is a significantly decreased head size. Or finally, clinical judgment, meaning there's a discussion between the family members and the clinician about, well, let's have an MRI as a baseline in case we want a basis for comparison if there are neurological changes in the future. In terms of repeating MRI, so let's say you have had an MRI already, what are the reasons for repeating that MRI? And again, we don't routinely suggest repeating an MRI if one has already had one, unless there's certain indications. And these indications include, well, there were seizures before, and now there's a sudden significant increase or change in the seizure frequency or characteristics. If there's changes to the neurological examination, if there's new or worsening developmental regression, or again, based on clinical judgment. In terms of EEG and seizures, again, the question comes up, well, should we get an EEG if we have a new diagnosis of Phelan-McDermid syndrome, should we just get a routine EEG? And the answer is we don't routinely suggest getting a routine EEG just for the sake of that. However, we do suggest getting an EEG if there are specific indications, meaning if there are events or spells that are happening that raise concern for a seizure, if there's suspected epilepsy, which is a seizure disorder, if there's developmental regression. And initially, we would, if there is concern enough that warrants an EEG, we usually start with what we call a routine EEG, which is usually in a short study, about 30 minutes or so. However, we do suggest getting a longer study which would capture sleep. If, for example, there's language regression and we want to look for if there could be EEG abnormalities during sleep that may be impacting language. And we also consider getting a longer EEG if the spells that are happening may not be captured within the 30-minute snapshot of a routine EEG. In terms of repeating EEG, again, similar theme. If somebody has had an EEG already, we don't necessarily getting a routine EEG or repeat EEG automatically unless there are specific indications. And these include, for example, there was previously significant abnormal activity, brainwave activity on the EEG, and we want to get a follow-up EEG because the results of that follow-up EEG may change our management in terms of our drug selection or other parameters. We would get a follow-up EEG if there are new types of symptoms that raise concern for seizures or if there's unexplained developmental regression that is occurring. And then sometimes we consider getting a follow-up EEG if there's a mismatch between kind of or if there's a significant plateau in one's development, or there's other features that raise concern for a regression. In terms of neurology considerations, if somebody has ring chromosome 22, again, this is a certain type of chromosomal anomaly that can predispose for certain types of tumors within the brain and other manifestations. In those who have a new diagnosis of ring chromosome 22, we would suggest getting an MRI of the brain and spine as a baseline with contrast and neurological examination. And then we suggest repeating that MRI every 1 to 2 years from the age of 10 years to 40 years, looking for these specific types of tumors that are found. And then we also suggest repeating that neurological assessment along with the repeat MRI. And then in terms of repeating spine imaging in somebody who has ring chromosome 22, we don't suggest routinely repeating spine imaging unless there's symptoms that suggest spinal cord problems, such as weakness in the legs, increased reflexes in the legs, bowel, bladder symptoms, and so on. I wanted to talk about a specific term called autoimmune encephalitis, which some of you may or may not have heard of. This is a neurological condition in which the body's own cells attacks its own brain cells, basically, that can cause changes in somebody's behavior, that can cause seizures and other neurological symptoms. And this is something that we're seeing a little bit more and more in Phelan-McDermid syndrome, and I think it's a condition that remains to be, that we need to characterize more and more. But the point being is that we would evaluate for an autoimmune encephalitis if there's, number one, an abrupt regression that's happening. Number two, especially if there's neuropsychiatric symptoms that are happening that are accompanied by significant neurological signs or symptoms such as seizures. And then we also consider this possibility if there's neuropsychiatric symptoms that are occurring, but they're failing to respond to the usual medications and treatments targeting these symptoms. We worry, could there be an underlying process such as an autoimmune encephalitis that's contributing to this? I'll include the workup that we usually do here. This is based on our PMS Project Echo Neuropsychiatric Consultation Group, which lists the set of labs and tests we consider if we're worried about an autoimmune encephalitis. This includes blood work, MRI, EEG, and in some cases even a lumbar puncture or spinal tap. In terms of treatment of an autoimmune encephalitis in somebody with PMS, so if there's autoantibodies detected, so again, these are antibodies that normally ward off against infection and so forth, but sometimes they start to recognize the body's own cells, including brain cells. So if we detect certain antibodies that are known to cause neurological issues, then we would consider treatment with medications that impact the immune system or suppress the immune system. That includes steroids and also something called IVIG. Sometimes, and this is a little bit of this statement, I think, just to be very clear, deserves a lot of nuance, but in somebody who has new onset of neuropsychiatric symptoms, neurological symptoms, in whom we don't identify a cause. We've done workup in terms of blood workup, in terms of MRI, EEG, and so forth, and who are really struggling and not responding to usual treatments. Sometimes we have a discussion with the families about empirically using some of these immune modulatory medications. But again, just to provide a lot of nuance to that statement, I think this is not a default thing. This requires a lot of discussion between the clinicians and the families, and I think this is an area that needs to be studied a lot further. I will put a plug in for a study that we're doing right now. So this is a study where we are trying to better understand why neuropsychiatric regression and decompensation happens in Phelan-McDermid syndrome. And one of our theories, it's just a theory, just the hypothesis at this point, is that there could be dysregulation of the immune system that primes the body to attack its own cells, including its brain cells. And we're trying to better understand the reasons for whether this is indeed the case or not. So if you're interested, eligibility for the study is a diagnosis of Phelan-McDermid syndrome with SHANK3 involvement, and age over 10 years. And if you're interested, there's a link to an email address you can reach out to us to learn more. So next, in terms of neurodevelopment, I don't think I have time to go into depth into each of these areas because they are so crucial and they warrant so much attention. We did cover the areas of how to optimize language abilities, cognitive abilities, daily living skills abilities, and came up with recommendations about pertaining to educational interventions, pertaining to interventions that clinicians who are caring for children and adults can adhere to, and recommendations pertaining to enrichment activities that the family can do. And again, for the sake of time, I won't go through these here. I've just put a screenshot of some of the tables we have in our manuscript, but I really encourage you to take a look at our full guidelines and look at these different tables which summarize all of these different features succinctly. And the same thing for behavior and sleep challenges. These are such important areas, and they almost, they warrant their own talks unto themselves. And so for the sake of time, I won't go through our recommendations in great detail here, other than to mention the tables and the text in our consensus guidelines go into detail in our formal recommendations. I will just mention a few points is that one of the things that we've learned over time in Phelan-McDermid syndrome is that certain types of medications can cause challenges. One example is SSRIs, which are selective serotonin reuptake inhibitors, which are often used for anxiety in general. Examples include things like fluoxetine or Prozac, sertraline, or Zoloft, and others. And not to say you cannot use these medications, but just use them cautiously because there can be different side effects and adverse reactions with use of these medications. The second caution, just to mention, is use of a certain category of medications called antipsychotics, which include things like Abilify, Risperdal, and others. Again, not to say that you can't use these class of medications in Phelan-McDermid syndrome, but to use them really cautiously and maybe try other things before using these classes of medications because they can precipitate what we call catatonia. And catatonia is something that we're seeing more and more in Phelan-McDermid syndrome. And this is a condition that represents a decreased kind of responsiveness to the environment. There can be lack of movement, there can be lack of communication, there can be agitation, confusion, increasing repetitive movements and behaviors, restlessness, a whole assortment of symptoms. So I think it's important that providers know to understand that catatonia occurs with increasing frequency in Phelan-McDermid syndrome, or can occur. GI issues, of course, are so incredibly challenging, I think, for families. And I think the important thing here is that sometimes GI symptoms can underlie symptoms that we might attribute to behavior, we might attribute to sleep problems or behavioral problems or growth issues or other challenges. Just so the point about this is just to be aware that there can be GI issues that can masquerade or present as symptoms that you might not typically see as related to the GI symptoms, GI tract, such as sleep or behavior. In terms of referring to a GI specialist, again, we don't by default refer to a GI specialist for anyone with a new diagnosis of Phelan-McDermid syndrome, but we would refer in the case of the presence of GERD or reflux, constipation, stool issues, or voiding, or issues with, or not voiding, but issues with vomiting, because all of these can be challenging in the setting of PMS and may require expertise. In terms of supportive GI strategies that may be helpful, a couple of things that are helpful in the general population may also be helpful in PMS, and that includes increasing fiber intake, because constipation can be a huge challenge. Regular physical activity, of course, is so meaningful and helpful for all sorts of things, but especially from the standpoint of gut motility, and sometimes, depending on the circumstance, pelvic floor therapy. And then when these standard therapies are not effective, then I think considering referring to what we call a neurogastroenterologist, somebody who is has extreme or significant expertise in gut motility, or somebody who has expertise in neurodevelopmental disorders or neuromuscular disorders and who understands the interplay between the GI tract and the nervous system. Rumination is a challenge that involves regurgitation of food contents. And again, some of the strategies that have been used in a typical population could potentially be helpful. Sometimes you can introduce some non-palatable substances via a G-tube. Sometimes behavioral approaches may be helpful if it's appropriate for the individual's cognitive level. And then in some cases that are challenging, don't forget to consider additional testing to make sure we're not missing out something else that's going on. In some cases, in a small percentage of cases, we do see elevated liver enzyme levels, which could reflect that there could be dysfunction occurring in the liver. A couple of things could underlie this. So one condition is something called autoimmune hepatitis, which is, again, where there's the body is attacking its own cells, in this case, its liver cells. Sometimes there can be fat tissue that affects the liver tissue that causes the liver not to work as effectively. And in some cases, individuals with PMS are on multiple different medications that can interact with each other and or have liver side effects. So it's important to understand or to note that that's a possibility too. In those who have functional gastric bypass, and what I mean by that, those who have had a surgery in which portions of their stomach may have been resected or removed, those who have a GJ tube, that can predispose you to certain nutritional deficiencies in Phelan-McDermid syndrome, and that includes copper deficiency, B12 deficiency, and neutropenia, which is a decrease of a certain type of white blood cells. So these should be monitored for in those who have this type of functional gastric bypass. Now, in terms of primary care recommendations, so for anyone with a new diagnosis of Phelan-McDermid syndrome, we talk about referring to ophthalmology as a baseline and having yearly assessments because there can be vision challenges. We usually talk about referring to hearing at the time of diagnosis to make sure hearing is not a challenge. And then we counsel about various things. And so we counsel about protective measures against overheating because that can be a challenge in PMS. We counsel about protective measures to protect against risk for skin infections. And then we counsel about different strategies that may be helpful in terms of addressing lymphedema, and I've included some of these things here. In terms of primary care recommendations specific to ring chromosome 22, for anyone with the new diagnosis of ring chromosome 22, I think, again, referring to ophthalmology for yearly assessments would be important. Referring to ophthalmology for yearly assessments is also important. Again, the difference here is that whereas for PMS, not due to ring chromosome 22, we think about a one-time audiology assessment, but for ring chromosome 22, we think about ongoing hearing evaluations because there can be certain types of tumors that affect the auditory nerve or the hearing nerve. And then we think about referring to dermatology, the skin specialist, for yearly assessments due to risk for certain types of lesions that can affect the skin due to ring chromosome 22. Physiatry pertains to clinicians who help in terms of tone management, whether that's low muscle tone or increased muscle tone, who help in terms of equipment needs, and who help in terms of mobility needs. We usually think about referring to physiatry after a new diagnosis of PMS. And usually we think about an annual evaluation by this team, focusing on range of motion, focusing on spinal alignment, and looking for any signs of leg length discrepancy. Physiatrists manage and help manage equipment needs. So if there are issues related to lymphedema and Phelan-McDermid syndrome, physiatry can be helpful in terms of making suggestions about compression garments, massage techniques, certain types of devices like pumps that may be helpful in this setting. In terms of therapeutic interventions focused on mobility, so physical therapy should focus on activities that promote strength and improve reaction time. Other types of modalities that may be helpful for gross motor functioning that are not traditional types of PT include things like aquatic therapy, which is a type of therapy where individuals work in pool aquatic settings. Hippotherapy, which is a type of therapy where kids work with or individuals work with horses, so it's the idea of strengthening core muscle tone. And then sometimes you can use adaptive tricycles, again, to promote gross motor skills. OT, or occupational therapy skills, can focus on fine motor measures and specifically things like daily living skills in terms of feeding, functioning, and utensil use, and things along those lines. From a kidney and urogenital tracts perspective, for anyone with the new diagnosis of PMS, we do think about getting a baseline kidney and bladder ultrasound because we can see structural kidney abnormalities in PMS. We also think about having a complete physical examination, including blood pressure, because that can be related to kidney function, including external genital urinary tract exam to make sure there's no structural abnormality. If there are concerns about urinary tract infections at a young age, or if there are concerns about frequent, significant urinary tract infections, we do think about a condition called vesicular-ureteral reflux, in which the urine contents migrate or go upwards from the bladder up into the kidneys and can cause problems. And there's specific testing that can be helpful for this, to look for this. If we don't necessarily think about repeating a kidney and bladder ultrasound if the initial one was normal, unless there's new or concerning symptoms, such as urinary symptoms that have developed over time, signs of urinary retention, signs of difficulty voiding or peeing, whereas child was able to go to the bathroom before without issues. In terms of endocrine concerns, for anyone with a new diagnosis of PMS, I think it's important for the medical team to note parameters, weight growth parameters, specifically what was the child's birth weight, what was their birth length, what was their birth circumference, just so that we're able to track that and have a basis of comparison. We don't routinely suggest thyroid function screening in PMS unless there's symptoms concerning for thyroid dysfunction, which I've included on the slide here, or if newborn screening did not occur for that individual. And if there's short or tall stature, we also suggest referring to endocrinology because both of these can be possible in PMS. Precocious, which means a precocious puberty, which means puberty occurring before it's expected, or delayed puberty occurring after it's expected, also would warrant a referral to endocrinology. From a cardiovascular perspective, for anyone with the new diagnosis of PMS, we suggest referring to cardiology to have an echocardiogram, which is an ultrasound of the heart, an EKG, and a formal examination by a cardiologist. In terms of gynecological care, these recommendations are in line with the general population. They're not specific to PMS, but they're still important nonetheless. We suggest HPV vaccination around the age 11 to 12 years of age, and between 26 to 65 years of age, there should be screening for cervical cancer every 5 years. If there is concerns about abnormal uterine bleeding, we do suggest making sure that we're not missing some other cause that's underlying this before we do symptom management. By default, if we don't suggest suppression of menses if it hasn't occurred yet, and if there's a desire to reduce the volume and frequency related to menstrual flow, then that is a consideration in terms of medications that may be, or options that may be helpful for addressing these symptoms. And then finally, just from a dentistry standpoint, this is similar to what's suggested for the general population, but I think it's important in PMS to establish a dental home by around 1 year of age or so and have dental evaluations every 6 months or so. Some key considerations, I think it's important when selecting a dental home to have a practice that is familiar with children with medical complexity. Sometimes anesthesia can be difficult for kids and adults with PMS, and so the practice should be aware of those sort of considerations. And then the other thing to mention is that sometimes kids and adults with PMS are on multiple medications, which can affect dental oral flora and can cause issues as well. So finally, just to mention from future directions, this is one version of these guidelines, or the second version of these US-based guidelines, and we're always thinking about how can we continue to revise and change these and update these over time. So that's our full intention, that as we continue to increase our knowledge, we hope to continue to update these guidelines reflecting what we know. And finally, just to wrap things up on some acknowledgments, thank you to the PMS Foundation for inviting me to speak and further involvement. Thank you to the Rare Disease, to the Developmental Synaptopathies Consortium. There's so many people who are involved in this consortium, too many to name here, but Dr. Alex Kolovzon in particular, who heads the PMS portion, Dr. Mustafa Sahin, who's my primary mentor at Boston Children's, and Dr. Thurm, who is a neuropsychologist at the NIH, but so many people to mention here. So I'll end at that. Thank you. And of course, thank you to the families. I think, I forgot to mention that. I think you are probably the most important, because I'm so lucky and privileged to be able to learn from you each and every day. So thank you.
Thank you. So welcome to my talk on the medical guidelines. I think I have to use either of the microphones. So you can see I've wrote European in brackets because I think it's the same intention as the US colleagues had, that they are meant internationally, globally for all families. But it was European based. So it's an honor to be invited by you, to speak in front of you. It's always heartwarming to meet you families, and especially the kids. I hope to see more of you later and tomorrow. My name is Michael. I'm coming from Germany, from a city called Ulm, that's in the south of Germany. Albert Einstein was born there. It's close to Munich. So I've been introduced, but let me just say you that PMS is really a very important part of my life. So I've been dealing with Phelan-McDermid syndrome for more than 10 years already as a medical student. And I've also helped to build up a PMS clinical center in Ulm. And I'm a board member of our family association. Also, I should send greetings from our association to the PMSF. And I've also organized symposia in Ulm, and I'm a scientific advisor to the PMSF. And I co-authored the European guidelines, which the talk will be about today. I also was asked by Sue Lomas to join an organization committee to build up an international federation of all family associations, which is still ongoing. And I'm currently the chair of a newly formed alliance of researchers and parents that's called the European PMS Research Consortium. In Europe, in Ulm, we have 3 pillars of care for Phelan-McDermid syndrome. So first, we have a research institute. We do basic research on SHANK3 and deficiency, headed by Professor Böckers. That's the person on the left. So this is the institute I'm working at. And then we have a Phelan-McDermid syndrome clinical center headed by Professor Dr. Sarah Jesse. She's a neurologist. And we have the Family Association of German-speaking countries, so Germany, Austria, Switzerland, which is also homed in Ulm. So the guidelines, how it all started, was quite the same time frame as for the US guidelines. So it was initiated really by our Dutch colleagues. So Annemiek Landlust is from that group. And the initiator was Professor Connie van Ravenswaay, who contacted us with the idea to build up a European consortium in order to write guidelines. And then we had a first meeting, of course, at that time, because of COVID, it was online in 2020. And then for 2 continuous years, we worked in different work groups on the guidelines, had always online general meetings. And then finally, in summer 2022, we had an in-person meeting to find consensus on our recommendations. And then later, we published all the chapters of the guidelines in a form of single articles in the European Journal of Medical Genetics in a special issue. You find also the link here on the slide. We were supported by network for rare diseases called ERN Ithaca, but we were not paid for this, so we had no conflicts of interest. And we followed, there's a certain, let's say, a guideline to write guidelines for rare diseases. It's called the AGREE 2 recommendations. And this means that apart from scientific evidence that is there for a disorder, it's also important to take into account the perspective of the parents. That's the same way that was walked by the US colleagues. So, as I've said, guidelines are developed by the experts of a disorder, but also by affected individuals, and by proxy in Phelan-McDermid syndrome, it's usually the caregivers, the parents. And a very central part of guidelines are, next to the scientific knowledge that is summarized, are recommendations for specific healthcare. And they create a standard of treatment and should be followed by all healthcare providers, and are also a very important basis for research. You see there's a huge list of persons who were participating in writing the guidelines. In black you see all the experts, in bold those who've led work groups, and in blue you see the parents that were also always, at least one parent was part of a work group. So the guidelines comprise 12 single articles, so let's say the chapters of the guidelines on various topics, and they each contain always consensus recommendations. There's also, because of course this is, if you would read all of it, it would be more than 100 pages or so, but we have also a summary of it called the clinical synopsis, and then we have 3 extra documents called a lay version, surveillance scheme, and an emergency card. These documents are especially useful for you, and Kate, I think she told me that this is also now available on your website, on the PMSF website, these summarized documents. I will explain you in detail what's in all of these documents. You also find the guidelines on a website from this rare disease network, Ithaca. So here's a QR code and the web link. Also the slides I will make you available afterwards, so you will also find it on your homepage. As I've said, so an important basis is always the perspective of the families. That's why we've conducted global. We not only wanted to have the regional perspective from Europe or so, we wanted to have a global view. This was this approach by Annemiek Landlust. So we conducted a worldwide survey, and almost 600 families responded to us, and you can also see that the US really contributed majorly, so thank you for that. So all continents participated, however not Antarctica. Not so many people there. We also asked, I just highlight a few findings of this survey. We also asked about the satisfaction families have with their healthcare. And it was really shocking, I would say, even that only 12% reported to have a well-organized care. So we saw really a massive need. Also, a very important question was, it looks a little bit complex, but we asked about stressors, so things that stresses you as families and with a life with Phelan-McDermid syndrome. So you see in this middle column here, you see here the average of the stress. So the stress ranged from 0, no stress, to 3, which is maximum stress. On the right column, you see here the percentage of those who said it's extremely stressful. So just also highlighting a few. So you see sleep deprivation caused by the sleep problems of the child causes in 30% of the parents an extreme stress. The most stressful issues for the families, for the parents, were communication with the child, and of course this is quite touching to not know what the child is bothering. So this is a big problem, and the majority of parents also reported that it's extremely stressful to not know, and this is really, you cannot believe it even in the 21st century, to not know if the adult care, healthcare, is as good as the child healthcare. And this is really, this is something we should tackle. So all this, plus the scientific evidence we had, this condensed into these 10 chapters, so these 10 topics, and you see there in general, you will see there are many commonalities between our guidelines and the guidelines that have been written by the US colleagues and the parents there. So it will be a little bit repeating what he was saying, but as a university teacher, I have to say repetition is everything so that you get experts. And there's also 2 extra articles which are really also quite readable. You see at the bottom, like the parental survey is really very nice, so from Annemiek's working group, and also one on the genes or the genetic background in Phelan-McDermid syndrome. I will start with the first chapter. I've chaired this working group and we've dealt with these topics, so the definition of Phelan-McDermid syndrome and to whom we address our guidelines. So what is Phelan-McDermid syndrome? You might think this is an easy to answer question. However, it isn't really. You've heard that maybe also in yesterday's talk and today in the morning. But usually you would define a syndrome according to a certain phenotype. So for example, you might know in Down syndrome that you have these facial external features that define this person has a Down syndrome. They also have a defined genetic background, of course. But we discussed this again. Is there a certain combination of phenotypes that indicates Phelan-McDermid syndrome? However, that's not possible in a PMS. So you cannot distinguish PMS individuals from other individuals. Usually they look quite healthy, so no strong external features, which is nice, but to detect it is also harder. So we used a genetic definition of PMS, and we followed a recommendation of a group that was headed by Katie Phelan in order to separate Phelan-McDermid syndrome in those individuals who have SHANK3-related Phelan-McDermid syndrome or who have SHANK3 unrelated Phelan-McDermid syndrome. So we have a lot of knowledge about SHANK3-related Phelan-McDermid syndrome. That's why we address our guidelines towards these individuals. So that means it's either a deletion of chromosome 22q13, so with a loss of one of the copies of the SHANK3 gene, or it's a mutation, a point mutation within the SHANK3 gene. However, we also point out that individuals with SHANK3 unrelated Phelan-McDermid syndrome should not be excluded from clinical care in PMS clinical centers, also not from research. This is especially important. Otherwise, this way we will never know if it's similar to SHANK3 related or not. And also, we also recommend to also include them into family organizations of Phelan-McDermid syndrome. So you've seen those figures, and I think but also there are many new families here, so maybe again, it's nice to know that, but I will not go again into detail too much about it, but as you know, our genome consists of these 46 chromosomes, and you've heard of that, but maybe nobody has ever explained it to you in the way or with a ball of wool. So imagine this is a chromosome 22, and actually a chromosome is really a thread, and this thread is a chain of letters, which we call the genetic code, and you see it has a short arm and a long arm, and here at the tip of the long arm, you see there are colored regions which are genes. So these are parts of that genetic code that code for a protein. And you see the third to the last gene on the long arm, that's the SHANK3 gene. That's why it's usually always lost when there is a terminal deletion of this end of the chromosome. But it's also enough if there's only one of 50,000 letters within that red region is affected, that's this case of variance. Like these unrelated cases, they have interstitial deletions, so if parts proximal to this SHANK3 region are affected, but this is still there, this is then SHANK3 unrelated. Looks more like a voodoo puppet, I guess, but yeah. Yeah, and also, you've also heard of this maybe yesterday, but not all of you were here, but this is what we are doing in our institute. So the basis of the function of our brain is communication between neurons that are the cells of the brain, and neurons communicate with each other. There's always a sender neuron, which you see on the left, and then there's a receiver neuron on the right. And the contact site is the so-called synapse, which is here magnified on the right side. So you can also, if you want to explain it to someone, that there is one neuron that wants to talk to the other neuron, and the receiver neuron should hear, so it's kind of the ear of that communication. And on this ear side, there is SHANK3, and it's important for the sensitivity of that ear that SHANK3 is there in proper amounts and functional. So if SHANK3 is not there or mutated, then the ear doesn't hear so well. And it's also important that this ear can be dynamic in response. This is we call synaptic plasticity, which is the basis of learning. I also want to point out, and this is also part of our research, that Schön is not only at synapses, so it's also present in other organs such as muscles or also immune cells. So that's why we think it also has this wide variety of phenotypes. We also wanted to know about the frequency of Phelan-McDermid syndrome in Europe. So we can estimate the real frequency of PMS in a general population that said that 1 of 8,000 individuals has Phelan-McDermid syndrome, up to 1 in 30,000. Maybe something in between. I think something like 1 in 10,000 or so. How do we know that? Nobody has ever in a certain population detected every individual with PMS. But what we know is we know the genetic background of individuals with intellectual disability and with autism spectrum disorders, and we know how common that is in PMS, so that's why we can estimate it. We collected numbers from 15 different countries in Europe, from clinical centers, from family associations, and came up with a number of more than 1,000 families in these countries, but on a population of more than 300 million. So for Germany, we have an apparent frequency of 1 in 400,000. The apparent frequency in Spain or Netherlands was higher. That just means it's not that it's more common in these countries, it's just that Spain and Netherlands is doing it better, so they detect more individuals with Phelan-McDermid syndrome, obviously. But still, you see, all countries have a very high, I don't know if it's the same word in English, but a high dark number of undetected cases. So this is also, I think, a mission for the future to detect more individuals. That's why we also recommend that all children with a developmental delay, because this is the most common thing for Phelan-McDermid syndrome, all of them have developmental delay, shall receive a genetic counseling. And this is especially important for syndromes such as PMS because they do not have these external features. They look healthy most of the time, and that's why if this is then the only trigger to start diagnostics, then of course we will never detect them. We also looked for medical problems and how prevalent they are. That's why a part of this project was also to review the fairly done characterization studies. We found some almost 24 of studies that characterized individuals well, and we've added the numbers and built up this table. This is a short version of the table. In the lay version of the guidelines, there's a more comprehensive one in the article. And we also compared the frequencies in deletions and also in variants on the right side. And as you can see, the percentages are quite similar between deletions and variants. But you also see that the variants or some problems do not occur in variants such as kidney problems or lymphedema, but that is explainable because in deletion cases you have also the loss of other genes apart from Schön. We also looked what we can tell about a typical course of life in Phelan-McDermid syndrome. However, we also found out that we have a massive gap of knowledge. That's why it's so good that you do these natural history studies here. But it's still a nice chapter, I think, and paragraph, so it's more anecdotal. And we also evaluated or finished clinical trials. I think it's also, we don't have the time now to go through this. We also evaluated if COVID-19 is particularly harmful in Phelan-McDermid syndrome. And I don't know how it's in the US, but in Germany still, although the pandemic is kind of over, but the authorities still recommend to vaccinate in syndromes with neurological problems to vaccinate from the age of 6 months on. So let me maybe very briefly go through the consensus recommendations of the different chapters. Very briefly, they have more a law-like character, so the specific recommendations of which drugs can be used and so on you find in the separate articles. So in the first chapter, we recommend that each family should be informed about the existence of clinical trials and the enrollment should be considered. Genetic counseling, Sid has already told you about it. It's important that the family receives proper genetic counseling, including the siblings, information about genotype, phenotype correlation, how high the risk for recurrence is, the availability of prenatal diagnostic testing, and it should be complete and up to date. And this is what Sid already said. one has to know if you have a deletion, if it's a ring chromosome that causes it, because there is a certain risk to develop these benign, not malign, tumors that affect nerve function. And then you would do this monitoring with MRI or hearing tests. Language and communication is very complex, but just to let you say, hearing should be checked, and it's important to have a multidisciplinary team who assesses the functionalities of pre-verbal and communicative skills, and it should also be addressed and supported by such a multidisciplinary team. We also say that these devices, these pads, these augmentative devices, they are very useful and they do not hinder active language development, but they might even facilitate it. Sid already told you gastrointestinal problems are very, very common also in other neurodevelopmental disorders, and they can also cause behavioral problems. Zinc deficiency is also something that Sid has mentioned, and let me go over to sensory dysfunction. This is also an intrinsic problem of SHANK3 deficiency. So some have problems with hearing and vision. Most have problems with a reduced perception of pain, which is of course dangerous if there is a trauma and you might oversee it because the child does not react to it properly. And it's important to use validated screening tools. Epilepsy might affect the majority of individuals over the lifetime, and it can also be overseen. So like absences, for example. That's why it's important if there is suspicion to do especially prolonged overnight EEG. And also if there are new neurological signs, as in the US guidelines, we recommend to do brain imaging and to attend a neurologist in order to work out a plan with anticonvulsant treatment. Sleep disorder is also intrinsic to Phelan-McDermid syndrome. However, it can also be influenced by somatic problems, by environmental problems, and also by some behavioral issues. The mainstay of treatment is always the sleep hygiene first, and then if this does not work properly, then one should think about drug treatment or also attending a specialist sleep center. Lymphedema seems to only affect deletion, individuals with the deletion, and should be treated accordingly, also maybe in a lymphedema center of expertise. Mental health, extremely complex again, many factors that contribute. Almost all the health problems can affect also the mental health, and there should be a baseline measurement in the very early childhood, and then monitored regularly the cognitive function, adaptive skills, and the behavioral functionality. Then to the organization of care, only 10% about said I have a well-organized care, so that's why we've had an extra chapter on this. So we recommend that there is a structure in which there is a coordinating physician, like a pediatric, who orchestrates a team, a regional care team, and is in contact with the Phelan-McDermid syndrome clinical center, and he would work out, when this whole team would work out an individual care plan, which also comprises a well-organized transition from child care to adult care. And also patient registry are important part and should be discussed with parents to be involved in those. Very shortly, coming to the end, we have these three documents which are really, I think, very useful for you as parents. So we have a booklet, which is really a summary of the whole guidelines in a lay language. Then we have a 3-page document, the surveillance scheme, which informs you about the recommendations for different periods of life. So just for an example, maybe you see there's in the field hearts and lungs, cardiac ultrasound should be performed at diagnosis, but only if there is a problem, then it should be monitored regularly. We have also this emergency card, which is used, you should always carry it with you, and it informs about the health problems in Phelan-McDermid syndrome. So on the left side, you see the general health problems. On the right side, this should be filled out by you, the specific individual health problems. We also heard from German families that they use it also in kindergarten for the caregivers there, so that they are informed about the problems of the child specifically. And finally, I want to mention or say we have this newly formed PMS research consortium, which evolved out of this guidelines consortium. We had such a nice collaboration. We identified knowledge gaps and are now starting collaborations, and I hope this is also helping for the future care in Phelan-McDermid syndrome. We will also conduct a survey soon. I hope you will be alert on that and you will respond as you did for the medical care guidelines. and we ask you there what you think is important for future research in Phelan-McDermid syndrome. So thank you very much again for being here, for listening today, and I'm open to your questions also afterwards. From the emergency card, I have some 100 copies with me, so if you want to have one, I can give it to you.
Thank you, Dr. Schön and Dr. Srivastava. If you could both go up to the stage for a few questions. Just FYI, everyone, we are right at 11, so we are going to take your questions because we want you to have an opportunity, but the next session will start at 11:15, so please don't go too far away. Same thing, you're going to scan the QR code or upvote other questions, and I really want to let you know that both of these guidelines are equally important, and we have all of them on our website, so you do not need to be in Europe for the European guidelines to make sense, and vice versa. So on our website, under About PMS, you have medical issues and clinical care, and all of this information is on here, all of the links. So I'll give it a couple of minutes in case anyone has questions before we roll into the next session on neuropsychiatric illness. We have a comment of thank you for including Shank 3 unrelated. That's really nice. I'm not sure if you all can see the questions, but we have one on autoimmune issues. Are autoimmune issues something that either exist or not, or can it develop over time? And either one of you can take any of the questions.
Sure, I can perhaps get started. So the question is it a question about prevalence, or is it about, could you clarify just the nature of it?
If anyone wants to raise their hand, I can bring the mic to you.
I can certainly I'll talk a little bit generally. I think we still need to study the question of autoimmune encephalitis and PMS more. I know there are cases of confirmed, of what we call seropositive autoimmune encephalitis, in which we can detect an antibody that attacks the brain cells. But there's also something called seronegative autoimmune encephalitis, where we think the person has autoimmune encephalitis, but we can't find the exact antibody that is attacking the brain cells. Both of those scenarios are possible within PMS. And this is an area I think we still need to explore a lot more to see, number one, what's the prevalence of autoimmune encephalitis in PMS? Number two, what type of antibodies in those who do have autoimmune encephalitis, what percentage of cases are due to a confirmed antibody, what percentage are due to seronegative autoimmune encephalitis. And then finally, three, I think we need to better understand what treatment modalities are helpful in these scenarios. There are some individuals who have presumed seronegative autoimmune encephalitis in PMS who've responded to treatment with medications that affect the immune system, such as IVIG, but we need to study that in more detail. What is the reasons, what treatment modalities work and don't work. So I think it's a very, very important area, and I think we need to study it more.
Thank you. One of the questions which I was mentioning at the start is there a notable difference between these two sets of guidelines? I would say if either of you can just comment on that they're pretty similar, but if there's anything in particular families should look out for in one or the other that you've noticed one of them might have.
So I do not see any major differences. I've really read the US guidelines very carefully. And it's also, I think it's a proof of what we know or what we've read, and also the perspective of the parents, that we come to the same conclusions and almost the same recommendations. There are, of course, some structural differences. I mean, you have this very comprehensive single article. I also like this format very much, and we have it more in a little different way with these single articles, and then we condense it in these extra documents that I've shown at the end. And you have also some extra chapters that we do not cover in extra or in specific dedicated articles such as gynecology or physiatry, but I think we still cover it within the surveillance scheme. We have an extra chapter on organization of care, which I think you do not address. So it's a little bit, we have some, it's like Burger King and McDonald's. It depends on the flavor.
And just FYI, if you ever think that there should be something on our website, it probably is. So again, this is under About Phelan-McDermid Syndrome, Medical Care. There's all links to all of these, and we're working constantly with international advisors. So Dr. Schön is on our scientific advisory committee, so this is not, a disjointed, separate pieces of advice. We have another question, if either of you know the general average age of onset for seizures.
So I think that's a great question. The question is about seizure age of onset. So seizures in PMS can happen at any age point in theory. So they can happen at childhood, in infancy, in childhood, in adolescence, or later on. Generally speaking, when they occurs a little bit more so in childhood. In the not in infancy, not in the first 2 years of life, but more so 3, 4, 5-ish in early childhood. But it's possible to happen at any time point in theory.
This next question is also for Dr. Srivastava. It says, for the first presenter, some of your recommendations mention regression as a driver for doing an MRI. What is your general definition of regression? And I should note before he answers this that our very next session is focused on neuropsychiatric illness, regression, and behaviors. But if you'd like to give just a brief answer to that.
Sure. So that's a great question, and it's an area again that I think is evolving or can be open to interpretation changes over time. In our guidelines, we define regression as loss of previously acquired developmental skills that were consistently learned, that were consolidated skills, and the loss occurring, for a good period of time, at least 3 months or so. And the reason we kind of define it as such is because sometimes there can be a loss of skills that were not quite solidly obtained. For example, if somebody's just starting to learn a word and they lose that word, is it because that's a regression, or is that a lack of consolidation of that ability going on? So I guess the principle, to go back to the question to summarize, regression is a loss of a skill or milestone in cognitive, language, motor, other, or adaptive self-help skill domain, and that loss is of a skill that you think is solidly consolidated and previously acquired, versus some skill that is a little bit more inconsistent or not quite consolidated.
I think the next question is for Dr. Schön or for either of you, but it asks, can you explain again really briefly SHANK3 unrelated?
Sorry, to explain what it is, or? Okay, yeah, maybe, can people see that? Is it coming from online? With this ball of wool that I've explained. So SHANK3 related means that there's a part of the chromosome 22 lost, including the SHANK3 gene. So I've visualized this with these areas on this thread of this chain of letter that builds up the chromosome, and this red area is the SHANK3 gene. So if the tip of this long arm of chromosome 22 is lost, so if I would use a scissor now, this would lead to a terminal deletion in the region 22q13, and this is then up to 108 or so genes can be lost in the very large deletions. And also a point mutation within SHANK3 gene is also SHANK3-related Phelan-McDermid syndrome. But there's also a version where you would cut out a part of this thread, which is proximal to this red area, and the red area is then still stitched to the rest of the chromosome. So it's still present. And then it's SHANK3 unrelated, but still there is a deletion of a part of the long arm of chromosome 22. I hope that's
explaining it well. I'm not a geneticist, so I think Katie Phelan would perform better here, but yeah.
That was great. I think we have a lot of other really great questions, but we're capturing them and saving them. And in the interest of time, I think we'll need to move on to our next session on neuropsychiatric illness. So please join me in thanking both speakers, and especially our speakers that travel internationally. They came a long way.